Hello there. Our lecture for this day is about stroke. I will talk briefly about stroke, the important point only. Now, stroke is the fifth leading cause of death in the United States after heart disease, cancer, chronic lung disease, and injuries and accidents. And it is the most common disabling neurologic disorder. Approximately 800,000 new strokes occur, and approximately 130,000 new people die from stroke in the USA each year. The incidence of stroke increases with age. Approximately 2/3 of all stroke occur in those older than 65 years. Approach to diagnosis. Stroke is a symptom of 4 key features. First feature is sudden onset. Any focal neurological deficit that starts suddenly, this is documented by history, should be regarded as stroke even until proved otherwise. Second feature is focal involvement of central nervous system, documented by history, neurological examination, and neuroimaging. Third, lack of rapid resolution. And fourth, vascular cause, acute onset, the age, risk factor, anatomy, and neuroimaging. We know it is a vascular cause from its acute onset and from the age, risk factor, anatomy, and neuroimaging. Acute onset. Usually stroke begin abruptly. Neurological deficit may be maximal at onset or may progress over seconds to hours or occasionally days. Progressive stroke, it means that stroke which progress for weeks or months, and this usually suggests a diagnosis other than stroke. Stroke produces focal symptoms and signs that correlate with the area of brain supplied by the affected blood vessel. In ischemic stroke, it usually produces more or less stereotyped pattern of deficit, while hemorrhagic stroke usually produces less predictable patterns. Why? You have to look for the cause. In global cerebral ischemia, as occur in, for example, cardiac arrest, it is not regarded as stroke yet. Subarachnoid hemorrhage is also now regarded out of the classification of stroke. We have, this is a rapid a review of blood supply of the brain. Blood supply of the brain is divided into anterior circulation from the carotid, both carotids, and posterior circulations from the vertebrobasilar artery. The anterior circulation usually supplies cerebral cortex, subcortical white matter, basal ganglia, and internal capsule. It consists of the anterior choroidal, anterior cerebral, and middle cerebral arteries, while the posterior circulation supply the brainstem, cerebellum, thalamus, part of occipital, and lower part or the lower gyra of temporal lobe. It consists of paired vertebral arteries which unify to form the basilar artery, and their branches are the pica, that's posterior inferior cerebellar artery, the anterior inferior cerebellar artery, superior cerebellar, and posterior cerebral arteries. Also to include the thalamo-perforate, thalamo-geniculate arteries. Symptom and signs of anterior and posterior circulation ischemia. How we can differentiate between anterior and posterior circulation. You see, aphasia is a conclusive symptom of anterior circulation, while diplopia, vertigo, and dropping attacks conclusively occur in the posterior circulation. Hemi or mono paresis occur in both, and the visual field defect also occur in both circulations. Duration of deficit. In TI, symptom and sign resolve completely, usually within 1 hour, plus no evidence of infarction. This is documented by CT or MRI. While stroke bears this focal neurological deficit, which may be improving, stable, or worsening when the patient is seen. Stereotypic TIA usually involve one site, while non-stereotypic multiple sites or distant, for example, cardiac origin. Stereotype, it means that it's occur on the same scenario at repeated times, while non-stereotypic, usually multiple sites, for example, showering from the heart, usually it may involve many vessels, although commonly it involves middle cerebral artery. Vascular origin. The term stroke is used only when focal neurological deficits are caused by vascular disease. That is not due to space-occupying lesion, not due to demyelination, inflammation, trauma, etc. Usually ischemia constitutes about 90% and hemorrhagic 10%. Differentiation between the two only feasible by CT. Don't attempt to diagnose or differentiate between the two by clinical and physical examination. You cannot start treatment on the basis of history and examination. Among ischemic stroke, large arterial occlusion occur in 35%, small arterial occlusion occur in 25%, cardiac embolism 20%, cryptogenic in 15%, and other processes 5%. Clinical findings. History, you should look for the predisposing factor. When you face a patient with focal neurological deficit, first thing you ask about is a previous TI, whether the patient have hypertension and diabetes. And other predisposing factor, of course, like heart problem or blood vessel problem or hematological disorder. Onset and cause TIA, stroke, progressive stroke, thromboembolic, vis embolic. Also, this should be partially solved from the history and examination. Physical examination should include general examination, vital signs, examination of the eye, neck, cardiac, temporal artery, and skin. You have to read about the benefit of examination of each general physical sign. For example, in blood pressure, if you find a patient, for example, hypertensive, it may be a cause of stroke or it may be a result of stroke. Also, examination of the eye is important, looking for fundus, changes of diabetes, etc. Examination of neck for carotid bruit, cardiac examination looking for AF, temporal artery examination excluding giant cell arteritis, and the skin examination, for example, purpura, etc. Neurological examination should include, in a patient with stroke, cognitive deficit, visual field abnormalities, ocular pulsing, nystagmus or internuclear ophthalmoplegia, hemiparesis, cortical sensory deficit, and hemiataxia. If you are in the casualty and you want to see whether the patient has stroke and or not, please follow this very easy and rapid assessment of suspected stroke, which giving a score, one score for each of unilateral facial weakness, unilateral grip weakness, unilateral arm weakness, unilateral leg weakness, speech loss, visual field defect, and also ask about loss of consciousness and seizure, which usually take a -1 score. If the patient have from -2 to 6, this is the total score from -2 to 6. Score more than 0 indicates stroke is a possible cause. This is very helpful score. Bossar scale, this is called the Rosser scale. Exclusion of hypoglycemia is a must in this score. This is by bedside blood glucose test. Language deficit comprehension include comprehension, naming, and articulation. Motor deficit, pronator drift, clumsiness of fine finger movement, sensory and visual inattention. You are all familiar with CNS exam. Investigation order should include blood tests like blood glucose, complete blood count, coagulation studies, inflammatory markers, serological assay for syphilis, circulating troponin level, ECG, and lumbar puncture in certain occasions. Brain imaging, non-contrast CT scan is the investigation of choice, or MRI if available. Diffusion-weighted MRI, perfusion-weighted MRI also important to diagnose stroke earlier than CT. Vessel imaging, Doppler ultrasound to see whether there is carotid stenosis. Digital subtraction, X-ray, angio. This is usually done when you attempt intervention, like for example stent or carotid arterectomy. CT angio and MRI angiography to localize the site of occlusion. Echo is very important to exclude heart problem like cardiomyopathy, presence of thrombus, intra-arterial thrombus, ischemic heart disease, etc. Differential diagnosis of stroke should include intracerebral hemorrhage, subedural and epidural hematoma, subarachnoid hemorrhage, SOL, seizure, hypoglycemia, and hyperosmolar non-ketotic hyperglycemia. Obviously, these could be easily excluded by history examination and CT image. Treatment include primary prevention, pre-stroke, TI and acute stroke treatment, and secondary prevention, that is primary prevention lifestyle change, which include exercise for 20 minutes 3 times in a week, healthy diet, weight reduction, quitting smoking, moderation of alcohol, and treatment of obstructive sleep apnea. Statin should be given for all patients with or without dyslipidemia. Usually given for those who are at high, more than 10% 10-year risk factor for CVS events. So every patient should you measure them the 10-year risk factor for cardiovascular event. It is available on the net. You can take a look for it. Blood pressure control by lifestyle, also modification or antihypertensive drugs, or both. For systolic blood pressure more than 140 millimeter mercury, or diastolic more than 20. Glycemic control also is very important in primary prevention of stroke. Antiplatelet, giving aspirin 81 to 100 milligram per day for patient, whenever it is indicated. Anticoagulation also given for patients, especially for AF patient with protein CNS deficiency, a patient post myocardial infarction, for example, patient with carotid artery stenosis, cavernous venous thrombosis, and any patient with a risk factor for stroke where anticoagulation is indicated. Asymptomatic carotid artery stenosis, we will talk about it later. Anticoagulation, I'm sorry, it's written wrong. Anticoagulation giving first for patient with valvular AF. In valvular AF, primary prevention of stroke according to Chad S2 VASC. You have to retain to your book to measure this score. Long-term warfarin INR target 2.5 plus minus 0.5. This is for Chad S2 VASC more than 2. If a patient have Chad S2 VASC more equal to 1, option include warfarin or aspirin or no treatment according to the patient. Chad S2 VASC 0, no treatment. Another indication of anticoagulation is patient with a non-valvular AF plus Chad S2 VASC more than 2. Drugs involved in this patient, that is without valvular heart, these include dabigatran, rivaroxaban, apixaban, and indoxaban. Mitral stenosis with history of embolism or associated with left atrial thrombus also we give warfarin. So, the drugs for thromboembolic cerebrovascular disease include anticoagulation, as I told. These include the antithrombin activators like heparin given IV to a PTT of 1.5 to 2 X2 control. Two times the control. Vitamin K antagonist, which include warfarin given per oral to INR of 2.5 plus minus 0.5. Direct thrombin inhibitor, which include dabigatran, also per oral, 150 milligram PID. Direct factor 10 activator inhibitor, like, as I told, apixaban, indoxaban, and rivaroxaban. Drugs, continue drugs for thromboembolic cerebrovascular disease. Aspirin per oral, 81 to 30, 300 to 5 milligram per day. Aspirin combined with dipyridamole, aspirin plus dipyridamole per oral, 25 on 200 milligram PID. Clopidogrel per oral, 75 milligram, given also once per day, I think. Thrombolytics. This is the famous drug, recombinant tissue plasminogen activator, RTPA, given IV 0.9 milligram per kg once, and also given intra-arterial, still not established. Acute ischemic stroke and TI. Medical treatment include medical treatment, interventional treatment, and surgical treatment. Medical treatment include blood pressure control, control of hyperthermia, hypoxia, hypoglycemia, anticoagulation or heparin, antiplatelet therapy, and statin. All of these should be optimized with except of blood pressure, which should not be decreased in the first few days or week. Interventional treatment include intravenous thrombolytics, intra-arterial thrombolysis, and clot retrieval. Intravenous thrombolysis, we gave the famous drug alteplase, given within 4.5 hours, can reduce disability and mortality from acute ischemic stroke. This is the window, 4.5. So a patient who sleep the night and wake with a deficit is contraindicated to give TPA. Treatment should be started within 60 minutes of the patient arrival to hospital, which provide time for diagnosis and evaluation of possible contraindications. Contraindication designed to avoid unnecessarily treating patients who are improving or unlikely to benefit. What do we mean by this? If you receive a patient, the casualty, who is improving or very minor deficit, there is no need to expose him to the risk of TPA. Contraindication designed to avoid the bleeding complication. Intra-arterial thrombolysis indicated for 3 groups of patients. First group include those who reach after the window time from 4.5 to 6 hours. Patient with recent history of major surgery and IV thrombolysis is unsuccessful. Clot retrieval, that is mechanical thrombectomy with a stent retrieval, typically in combination with IV RTPA, can improve functional outcome for patients with stenosis or occlusion of the proximal, that is internal carotid or proximal middle cerebral artery, intracranial arteries in the ACC. Those who fail IV, the second group of patients, those who fail IV thrombolysis or not candidate for, but should start 6 hours after starting of symptoms. Surgical treatment include first carotid end arterectomy, which is indicated for 2 groups of patients. First TIA and high grade, that is 70 to 90% extracranial internal carotid artery stenosis. The second group of patients are selected patients with moderate, that's 50 to 70% stenosis. This is carotid end arterectomy. Second surgery or surgical intervention in stroke include carotid artery stenting, as effective as carotid end arterectomy. Third operation called decompressive craniectomy with dural expansion, indicated for two conditions: cerebellar infarction and second large hemispheric stroke, if occurs in less than 60 years and deteriorate within 48 hours. That is the age less than 60 and deterioration within 48 hours. Secondary prevention includes statin, atorvastatin 80 mg per oral per day. Not 20, please, not 20 mg as our colleague usually give. Blood pressure control, the best drugs after stroke is diuretic and ACE inhibitor. Antiplatelet for non-cardiogenic stroke. If occur while taking aspirin, if a patient has stroke on his own aspirin, there is no role for adding clopidogrel. You may try other option of treatment. Anticoagulation, I said the indication. As a secondary preparation, mainly for cardiogenic, especially AF. Indication and INR target is also important. You have to read about surgical treatment the same.